share my slides in a second. Great, thank you very much for the introduction. So, as Rachel said, my name is Laura and I'm currently a scientific advisor at NICE, but previously worked as a statistician and health economist in Sheffield, predominantly working on clinical trials research. So today I'm going to talk about some of my doctoral fellowship research, which was looking at how we can use health economics in the design and analysis of adaptive clinical trials. So just a quick, excuse me, a quick disclaimer to begin with. This research was all conducted previously to my role at NICE, and also was funded by the National Institute for Health and Care Research. So all views are my own and don't sort of represent the views of NICE, the NHS or the NIHR. I'd also like to acknowledge the support I received from my PhD supervisors in this work, and also a public advisory group who supported the fellowship as well. So in this presentation, I'm going to give an overview of the work I did during the doctoral fellowship, and I've deliberately tried to keep the technical detail to a minimum, but I'd be very happy to kind of speak separately if anyone's interested in some of that technical detail. And also I'll reference some of the papers where some of that more technical detail is published, so you can have a look if you're interested. So I thought what I would do is kind of give a bit of background and an overview of why I thought this was an important area to research, and then focus on two aspects of methods development, focusing on how we should analyse, we'll do our health economic analysis following an adaptive design, and using value of information analysis methods to design our adaptive trials. And I'll end by making some recommendations that will hopefully be useful to you when you're thinking about your economic evaluation alongside adaptive clinical trials. So as I'm sure you're all aware, healthcare systems around the world are faced with limited resources for funding healthcare treatments and health research. And this means that we have to try and prioritise treatments that give us the biggest improvements in health for the money that we're spending. And we often rely on evidence from research, such as clinical trials, to inform these treatment decisions. And so we really want to fund research that helps to accurately inform which treatments we should be purchasing and sort of making available to our patients. And so partly in response to this limited funding for conducting clinical trials, the methods of adaptive designs have been proposed as an innovative and efficient alternative to the fixed traditional clinical trial. And so in this sort of traditional context, we would design our trial, we would collect all of the data and then save our analysis until the end of the study. But in the adaptive design, we have this opportunity to review the data as it's being collected and adapt the trial. So this could be something like stopping the trial early because the evidence suggests our new treatment's working really well, or it could be maybe adding or dropping treatment arms as the trial progresses. And we do these at pre-specified interim analyses, early examinations of the trial data. And this approach is becoming more popular because it can save us time and resources and help us to get treatments to patients as soon as possible. But at the moment, these early examinations of the data tend to be focused and informed by evidence of clinical effectiveness. But in addition to generating evidence of clinical effectiveness, our clinical trials, and therefore our adaptive designs, can play a really important role in providing evidence of whether a treatment's cost effective. So collecting evidence of quality of life and also the costs associated with a particular treatment, because we need to balance how well a treatment works with how much it's actually going to cost us to make sure that we're getting the best value for money out of our limited treatment budgets. But at the moment, this is often neglected in our adaptive clinical trials because we tend to focus the adaptations and kind of these early examinations on the data on evidence of clinical effectiveness. And by neglecting cost effectiveness, we are potentially compromising the accuracy of a subsequent health economic analysis, and maybe even missing opportunities to incorporate health economics into the adaptive design itself and increase the efficiency of these designs even further. So this was kind of for me, I thought was an area of interest because one, we didn't want to be making any mistakes because we've used an adaptive design when it came to our health economic analysis, but also because we were striving for more efficiency from our health research, is there an opportunity to take this kind of one step further? So what I wanted to do was to try and understand the current kind of landscape and see what current practice was around the use of health economics in adaptive design. And to do this, I reviewed the sort of clinical trials literature to identify clinical trials that had an adaptive design of any type and a pre-planned health economic analysis. And I extracted information about how the health economics had been used in the design of the study, how it was handled when it came to the analysis of that adaptive trial, and how the results were reported. And so the full results of this review were published in Value in Health. But I thought I'd just pick out a couple of the key ones that really shaped the next steps in terms of the kind of methods development. And so what I found, I was able to identify 37 clinical trials, and of those 37, we felt that 3 had thought about the health economics in the design of the study. And in those that we thought it was necessary, none of those trials actually adjusted their health economic analysis to reflect the fact that the data had come from an adaptive clinical trial. I also went through guideline documents from health technology assessment agencies to see what advice they provided to researchers who were submitting evidence to them that might have come from an adaptive clinical trial. And so I looked at guidelines from NICE and from the Pharmaceutical Benefits Advisory Committee in Australia. And so I thought I'd just pick out the Australian results here. And this guidance document was one of only 4 that mentioned adaptive clinical trials. And it kind of says that, in some scenarios,
I'll see you tomorrow. Bye.
In some scenarios, adaptive designs might be appropriate, but it's important to kind of justify that choice, especially if you're using data from an early interim analysis in the trial or from a trial that stopped early. But there was not really any practical guidance on how exactly a health economist or a statistician might present that information or exactly what the issues might be. So although it kind of ticks the box in terms of mentioning adaptive designs, none of the guidance documents really provided that hands-on advice on what to do. So at this point, I think it was clear that the methods of adaptive designs are quite well established, and so are the methods of health economics, but they're not really being used together in practice. And so I wanted to understand a bit more about why this might be the case, where there's certain barriers or limitations that were preventing people from using adaptive designs and health economics together, and why we weren't really thinking much about the economic evaluation alongside adaptive trials. And so to try and understand the key issues, I conducted a qualitative study with key stakeholders to understand what they thought about the use of health economics in the design and analysis of adaptive clinical trials. So I used semi-structured interviews and focus groups with members of the public, researchers and decision makers to try and get a more detailed understanding of what they thought about the issues around economic evaluation and adaptive designs. And so as I started to analyse the data from these interviews and focus groups, there were 3 key themes or categories that started to kind of come out of the data that kind of were recurring issues that lots of people were mentioning. And they were kind of focused on ethical issues, methodological issues, and then the kind of practical implementation side of things. So the full results are published in Trials, but I kind of picked out the 3 that really shaped what came next as well. So one of the key things that I found was that for many of the stakeholders, not all of them, but for many of them, they felt that clinical effectiveness should be the main focus of a clinical trial. And I guess that kind of reflects the reasons why adaptive designs and just general clinical trials tend to focus on clinical effectiveness during the study. And so that made me think that maybe we need to keep this in mind when it comes to any new methods development, to make sure we're not kind of developing a method that wouldn't be acceptable to many of the stakeholders in practice. Again, there seems to be a lack of awareness about the potential for an adaptive design to impact on an economic evaluation, and that perhaps there were some issues that were being overlooked because the economic evaluation or the health economic analysis was being conducted as if the data was coming from a traditional fixed clinical trial. And interestingly, for those stakeholders that were sat on funding panels, so those committees that kind of allocate our limited research funding, a lot of them talked about using these informal rules of thumb around deciding whether something was going to be value for money or cost effective. And they weren't really using routinely the methods of value of information analysis that kind of formalize these rules of thumb to help them make these decisions. So I thought maybe there was an opportunity there to think about how these methods could help to formalise the rules of thumb that these funding panels use to allocate funding to clinical trials, including adaptive designs. So at this point, the key issue that stood out to me was the lack of awareness of the potential for an adaptive design to impact on a health economic analysis. And I was concerned that if we were just doing our economic evaluation as if the data had come from a traditional clinical trial, we were perhaps compromising the accuracy of our health economic analysis, which is obviously a big issue because that data can play such an important role in the allocation of treatments to patients. And we don't want to be in a situation where we're maybe allocating resources to a treatment that isn't truly cost effective. That's where I focus my attention next, to try and make sure that we can make the most of the benefits of adaptive designs, but without compromising our economic evaluation. And so at this point, I decided to focus my attention on group sequential designs, which is a common type of adaptive design that's well established within the adaptive designs literature. And essentially, in these designs, we examine the accumulating data after groups of patients have reached our outcome of interest. And at these pre-specified interim analyses of the data, we evaluate whether we've got sufficient information at that point to stop the trial early. So this might be stopping the trial early for efficacy because our new treatment is working much better than we expected, or maybe stopping because the treatment isn't working as we thought and it's better just to stop the trial at that point. But as I mentioned earlier, these decisions around whether to stop or continue the trial are commonly focused on demonstrating the clinical effectiveness of the intervention. And so it's well documented in the group sequential designs and the adaptive designs literature that our treatment effect estimate can be biased when we use a group sequential design. So our point estimate of our primary outcome might be biased upwards if we decide to stop the trial early for efficacy, and it might be biased downwards if we stop the trial early for futility. And it's been shown as well that our secondary outcomes, if they are correlated with this primary outcome, they are also vulnerable to bias. And so this raises concerns for any health economic outcomes that we collect during the trial that might be correlated with a clinical outcome. So as a really simple kind of toy example, if we imagined we had a new treatment for reducing blood pressure, so that's our clinical primary outcome, we might also during that trial collect information about changes in quality of life of those trial participants and also the costs they incur during the trial. And so we might expect if someone's blood pressure reduces that their quality of life might improve, and they may also incur less costs because they need fewer sort of trips to the hospital and less medication generally to control their sort of symptoms. And so it's feasible that our health economic outcomes are correlated with the primary clinical outcome, and therefore we might introduce bias into our health economic analysis if we're using a group sequential design to collect that information. But luckily, because this is quite a well-known issue in the adaptive designs literature, there are lots of adjustments that are available to us to kind of control for this bias in our point estimates and our confidence intervals. And I focused on one known as the bias adjusted maximum likelihood estimate. And this allows us to take our usual maximum likelihood estimate and subtract an estimate of the bias to give us a bias adjusted maximum likelihood estimate. And we can do a similar type of thing for our secondary outcomes as well, that kind of takes this estimate of the bias and uses the correlation between the two outcomes to give a bias adjusted maximum likelihood estimate for the secondary outcome as well. But my sense was, and I wasn't able to find anywhere in the literature where this approach had been applied in the context of a health economic analysis. And so what I wanted to do was to explore the impact that a group sequential design might have on an economic evaluation that's kind of conducted alongside that adaptive design. And so I used a simulation study of 2,000 trials to see what happens if we did adjust for the adaptive nature of the trial, and if we didn't, and what impact that might have on our results. And so I looked at both a within trial and a model-based cost effectiveness analysis. And I also looked at some of those trial characteristics that have been shown in the literature to influence the level of bias we might get in our analysis. So things like correlation, the stopping rule we use to help try and decide whether to stop the trial early or not, and then the number of times we look at the data early. And so I based this simulation study in a real world example known as the CACTUS trial. And in this trial, they compared a computer-based intervention for speech and language therapy for patients who had aphasia following a stroke. And so this was a small pilot study that did have a model-based health economic analysis. And so in a simulation study, I imagined simulating the full-scale trial using a similar design and kind of following on from the pilot trial. So I've just picked out a couple of results here to kind of illustrate what might happen in our health economic analysis following this trial. And so we can see here are the results for a group sequential design that uses a Pocock stopping rule with 5 analyses of the data. And we can see that as we vary the correlation between the primary and the health economic outcomes, for the primary outcome, the bias is fairly consistent. But then when we look at our health economic outcomes, so here that's costs, quality adjusted life year, and then they're used to calculate an incremental net benefit. As the correlation increases between the primary and the health economic outcomes in the trial, the bias increases quite a lot in those outcomes. So if we're not adjusting, so if we're using an unadjusted analysis, that's the blue line, then we're getting quite a lot of bias. But this is reasonably well controlled if we actually use our bias adjusted maximum likelihood estimate. And so for the same trial design, here's the within trial cost effectiveness analysis results. And so in our adjusted analysis, if we look at our incremental net benefit, we can see that it's fairly consistent even when we've got high levels of correlation. So we've got a negative incremental net benefit, suggesting our computer-based intervention is unlikely to be cost effective. But when we look at the unadjusted analysis, so where we kind of ignore the fact this data comes from a group sequential design, we actually get a switch in the direction of the sign for the incremental net benefit, which in theory would mean that we now might think that the computer-based intervention is cost effective. Obviously, I appreciate these numbers are all quite small and I've not presented confidence intervals, but I guess what I want to try and do is highlight the fact that we could be in a scenario where in our unadjusted analysis, we're potentially making the wrong decision about the cost effectiveness of the computer-based intervention, and really emphasize the fact that we should be considering an adjusted analysis when we're using data that comes from an adaptive design. And so I think, yes, that there is just clear potential for an adaptive design to introduce bias into our economic evaluation. And we need to be really aware of this issue and thinking carefully about what adjustments are appropriate for our analysis following these types of trials. And so that, I think, addressed part of the issue around whether an adaptive design can impact an economic evaluation and what we might do to try and handle that. But as I found from the qualitative study, opportunities are potentially being missed to design, to help inform the design of adaptive trials by using health economic considerations. And as it was highlighted in that qualitative study as well, many of the stakeholders wanted the clinical effectiveness to remain the focus of the trial. And so what I decided to do was to think about how we could use health economics to inform the design of an adaptive trial. But once that trial was running, the focus of any adaptations to the trial remained clinical effectiveness. So rather than using cost effectiveness at an interim analysis, we were using it at the design stage, and then the trial would run as it would normally in terms of the adaptations based on clinical effectiveness. And so I drew on existing methods known as value of information analysis to do this. And so very briefly, the methods of value of information analysis allow a researcher to calculate the cost effectiveness of their research, essentially, by quantifying how uncertain they are about making a decision around whether to allocate funding to a particular treatment. And it might be in that particular scenario that it would be useful to collect a bit more information to help reduce that decision uncertainty. So they might want to conduct maybe another clinical trial. But obviously research comes at a cost. And again, we're in this situation where we need to balance the value of the extra research against the costs associated with it. And so in this research, I kind of focused on three concepts within value of information analysis. So the expected value of perfect information, which would gives us an idea of the value of eliminating all the uncertainty in our treatment allocation decision. And perhaps more realistically, the expected value of sample information that helps us to calculate the value of eliminating some of that uncertainty. And then related to that is the expected net benefit of sampling, which is essentially the difference between our population expected value of sample information and the costs that would be associated with conducting that specific research design. And so these methods are being used more commonly in our traditional fixed sample size designs, where we might say have a few options for the sample size of a clinical trial. And it might be that increasing the sample size of a trial increases the costs, but it may not actually reduce our uncertainty that much. So we might be better off going for a smaller sample size with a smaller cost. It might be a more cost-effective use of resources to use that sort of smaller sample size design. And the value of information analysis approach helps us to kind of inform that decision. And so these methods are used already at the moment for the fixed design. So I wanted to really think about what additional steps and additional things do we need to consider if we want to take those existing methods and apply them to the design of our adaptive trials. So the key thing was making sure that we use appropriate adjustments, as I've kind of highlighted in the previous slides, to reflect the fact that we're now thinking about adaptive trials rather than just traditional fixed trials, and also thinking about how we can accurately calculate the costs, potential additional costs and potential cost savings of our adaptive designs. So they were the key two aspects that I felt were slightly different when we're applying this approach in the adaptive design context. So again, I wanted to explore how these methods might work in practice and the steps that a researcher or a health economist or statistician might need to go through if they want to apply this to their kind of real world context. I imagined that we were designing a clinical trial following on from this pilot study. So again, using the Pocock and O'Brien-Fleming stopping rules. So once the trial is running, only thinking about the clinical effectiveness and looking at the data between 2 and 5 times during that trial. And so I also used the adjusted and unadjusted approaches to compare what difference those adjustments made during the study. So in this graph, again, it's just one scenario. In the first point, we can see that this is the actual cost that the intervention was anticipated to cost in the pilot case study. And we can see that actually the O'Brien-Fleming stopping rule, where we looked at the data once during the study and then the final analysis, was actually the most cost-effective design. But as we increased the cost of the interventions, it became more costly to randomise participants and to conduct the study. The designs that had 5 analyses of the data, so 4 interims and 1 final analysis, became more cost-effective because they, on average, had a smaller sample size. And so when it becomes really expensive to randomise participants, it becomes more cost effective to have fewer participants in the study. So I just wanted to make a quick note about the adjustments in this case. So in the hypothetical case study, the adjustments made very little difference to the estimate of our expected value of sample information. And I think that the adjustments and how much influence they have is really context dependent. It really depends on kind of your particular scenario. But I think it's really important that we still adjust our analysis, because we can't necessarily know where we're going to lie in terms of what impact that they're going to have before we conduct our analysis. I think the reason it can make a big difference, or it might not make a big difference, is to do with where the decision uncertainty is and what impact the expected value sample and the adjustments have on our decision uncertainty. So we know that our expected value of sample information changes when we have a change in our decision uncertainty. So perhaps when we move from one quadrant in the cost effectiveness plane to another, or cross the willingness to pay threshold. And so if we have a situation where our bias adjustment doesn't really shift us across that willingness to pay threshold, we're not really going to expect much change in our expected value of sample information, even if we've got quite big differences in terms of our point estimate of cost effectiveness in our adjusted and unadjusted scenarios. But where we're in a situation where perhaps the adjustment takes us from one side of the threshold to another, we're going to expect quite big differences in our expected value of sample information. But like I say, I don't think we can necessarily know this in advance. And so my recommendation would always be to consider this approach using both the adjusted and unadjusted analyses. So what I've hopefully briefly shown you is that there is an opportunity to use health economics to help us guide the design of adaptive clinical trials that then continue to focus on clinical effectiveness in terms of the adaptations once the trial is running, reflecting the fact that many of the stakeholders in the qualitative study were keen to see clinical effectiveness to still be the main aim of the trial. So what I'm now going to do is hopefully summarise some of the recommendations that I think are important for us to think about when it comes to conducting the economic evaluation of adaptive designs. And so in terms of design, I think this idea that many participants in the qualitative study see the clinical effectiveness as being the main aim of a trial should be always at the forefront of our minds in terms of our methods development. And that's not to say I don't think we could use cost effectiveness to inform adaptations to the study. And in fact, some of the work I've done after this project really does think about how we could have cost effectiveness stopping rules during the trial. But we maybe need to think about how it's implemented, and we could even have perhaps a hierarchy of stopping rules where clinical effectiveness is considered first, and then based on those results we think about cost effectiveness to adapt the trial. And I think the key to getting this right is making sure that we involve members of the public and all stakeholders in the design of a study. It's not sort of us, the methodologists, in a kind of silo trying to make these decisions and potentially coming up with designs that aren't really acceptable in practice. In terms of implementation, I think we're at a bit of a crossroads where these methods are starting to be developed in the theory, and there's maybe a bit of a bridge between that theory being implemented in practice. And I think more training would be useful to help health economists, statisticians, and the whole research team to really understand why this approach might be better, and also the issues that need to be handled to maintain the accuracy of our economic evaluation when we're using these adaptive trials. I think we might need more resources, especially at the sort of planning and design stage of these studies, because these designs require a bit more resource when we're kind of proposing our designs to funders, and this might need a little bit more time and may need to be funded separately to the funding application for the full trial. I think in terms of analysis and reporting, my key message is that we should be presenting both the adjusted and unadjusted health economic analyses, and this covers all bases in terms of making sure we maintain the accuracy of our economic evaluation, and also reflects the consort extension for adaptive designs that says we should be reporting methods for adjusted and unadjusted analysis approaches. And this really helps anyone kind of using the information or the analysis that we've conducted to work out what's most appropriate in their case, and can see what impact the adjustment has had on the results of the study. So just to kind of wrap up and I guess summarise some of the key messages from this work, I think there is a great opportunity here to think about how health economics is used in adaptive designs, because this could help to improve current practice by maintaining the accuracy of our health economic and economic evaluations, and also potentially increase the efficiency of our health research. It's really important that we don't just kind of try and do our economic evaluation as if the data comes from a fixed traditional clinical trial. I've shown that there is potential for the adaptive design to introduce bias into the health economic analysis, and we don't want to be compromising any future sort of healthcare decision making because we've not sort of appropriately adjusted our results. In this study, the stakeholders kind of felt clinical effectiveness should remain a priority. And hopefully I've shown you a way that we could use health economics a bit more to design our adaptive trials, but then that clinical effectiveness maintains the focus in the way that the adaptive trial is conducted following on from that. But I think it's really important that we look for opportunities to use adaptive designs and to use health economics as part of adaptive designs, but we make sure that we're not compromising the accuracy of any subsequent health economic analysis by using these adaptive trials, because we really don't want to sort of diminish the benefits that we might get from these more innovative and efficient adaptive designs. And so by thinking about the two together along the whole process, we can kind of maintain the accuracy of our analysis and our economic evaluation. Thank you.
Excellent. Thank you very much, Laura. That was really interesting. A lot of food for thought there. I've got a couple of questions there, perhaps more questions of clarification that I might start off with, if that's okay. So the first one was in your scatter plot where you had your sort of red and green scatters. I wondered if you could just bring up that slide. Mm-hmm. So in this graph you're showing, in the green I think was your unadjusted and your red was your adjusted, is that right?
Yeah, that's right. Yeah.
And so in terms of the uncertainty, you've got, perhaps less uncertainty with your, where your red scattered points are. But I just wanted to clarify, this was this is simulations for the cactus study, or was this looking at, more studies together?
So this, I guess, is it's not really related to the cactus study. It was more trying to illustrate the potential where the adjustments might make an impact on the expected value of sample information. So it's just a kind of a simulation of costs and quality, not really related to the trial. But so these points are kind of your usual cost effectiveness sort of probabilistic sensitivity analysis results. So if you imagined you had, you'd done some bootstrapping or you'd done a parametric sensitivity analysis, you'd have lots of incremental costs and qualities. And so I kind of just simulated some that were adjusted and that weren't, to try and show that if you're at a situation where you on one side, and not for the say adjusted, you're on the left of the willingness to pay threshold, but on the right you have adjusted, and you kind of your decision shifts. Because of that adjustment, you would expect there to be a bigger difference between your adjusted expected value sample information and your unadjusted expected value sample information.
Sure. Okay. Thank you for that. No, that's really helpful. So while I'm going with my second question, if you could please post your questions in the chat. And also, if you'd like to talk about a trial or a study, an adaptive trial that you're working on, you can, feel free to discuss, make a statement, a point, or a question about that specifically. So the second point of clarification, again, when you were looking at the VOI, you'd made a statement about more interim analyses were more cost effective, and that was driven by fewer participants in the sample. Is there a situation in some adaptive trials where, as you progress, you might actually end up with more in the sample than less? I just wasn't sure whether that's something that's going to hold with all types of adaptive designs. I mean, thinking about some adaptive trials and platforms where more and more participants are added as you go along, rather than testing out drugs where you end up with fewer groups in your N sample size. So I was interested in why the more interim analyses were always more cost effective.
Yeah, so again, I guess it should maybe be made clearer that these results are kind of context dependent, and they're kind of in the context of the cactus, like imagining what we're running the full scale trial for the cactus pilot. These are the results that we got, and yeah, I definitely think that it's very context dependent, and you're absolutely right that sometimes the benefit of our adaptive design isn't that we can stop the trial early. It might be that we actually carry on a bit longer, and the benefit there is collecting more information and reducing our uncertainty. So you're absolutely right that there might be some situations where it might be that having a longer study is actually more cost effective, because it might be, I guess, a situation where it's really cheap to randomize participants and we're very uncertain about we've got very little information about which treatment is best, and so we're in a situation where running for longer is better in terms of the cost effectiveness.
No, thank you for that. Richard, are you happy for me to pull up some questions from the Q&A, or did you want to pose the next questions from Haitham Tufahar?
I'm happy for you to do it, Rachel. That's fine. Thank you. Okay.
So Laura, this question is from somebody who's got a bit of experience with a VOI, and the question is: was EVSI calculated for all parameters, or the clinical parameters of interest in the Cactus trial? What's your approach when the parameters of interest based on the expected value of partial perfect information, the EVPPI, are different from the clinical ones?
So I guess firstly, I didn't look at EVPPI in this work, and it's a very, I guess, natural extension to try and understand how that might fit within this framework. So the EVSI, I think from memory, was calculated for
all parameters or the clinical parameters of interest?
I think it was all parameters. I'd have to double check the paper, but all parameters. But I definitely didn't think about the EVPPI. I guess my thinking was kind of keep it simple to begin with, and then see how it could expand after that. And it's definitely an area that could potentially be quite interesting, because it could be that you could continue the study or design the study to focus really on those parameters where there's most uncertainty, rather than all parameters that were in the health economic model. So definitely a point to think about, I think, in a bit more detail.
Okay, thank you. The next question is from Lisa Higgins. Thanks for a fabulous presentation, Laura. Have you done any work considering the impact on non-concurrent controls on health economic analyses of adaptive designs? For example, when a control group is stopped early and active interventions continue?
So no, I haven't. And again, I think it's obviously, I guess you're getting into the area of maybe of like multi-arm, multi-stage trials, and how this might all fit together in that context. And so again, I sort of focus on the kind of simplest group sequential design in this work. But I think these types of designs where you're maybe continuing with some of the treatment arms and dropping others is something that's really, I think it's shot up in terms of popularity because of COVID. And I think it's an area where these methods could be quite interesting, because you might have quite expensive arms, or you might have quite cheap arms where it's worthwhile just continuing because it's not costing you a huge amount of money. But it's not something that I've looked at, and it's definitely, I think, something at the moment that could be quite interesting to kind of carry forward.
Sure. I mean, Lisa, if you wanted to come off mute, then maybe you could extend that a bit further. I had wondered, Laura, whether whether any of your colleagues in the UK have, perhaps applied some methodological research either alongside recovery trial or any of the other COVID trials, where there's a continuation of working through interventions.
So I'm not aware of anyone currently doing it at the moment, because I mean, there's, as well as the COVID trials, there's also the Stampede trial, which is kind of a big prostate cancer trial that's running in, it's been running for a long time, and this is one of the big multi-arm, multi-stage trials, and that's probably quite a rich kind of case study and data set where you could really think about how to apply this approach, and could cost effectiveness have informed some of those decisions to add or drop treatment. So not currently aware of anything, but yeah, definitely there's definitely scope, I think, for these MAMS trials to apply these methods, and they could be quite actually informative for the adding and dropping of treatment arms.
Lisa, I don't know, did you want to expand on any of your questions? I know you've got a little bit of experience, or, you know, facing conundrums in your analyses at the moment.
Facing many conundrums. So Laura, just by background, I work in the REMAP CAP trial, which is an adaptive platform trial in ICU that most of our recruitment is actually in the UK. And we're doing some health economic analyses of some of our domains at the moment that I'm working with Philip Clark and Liz Stokes on, who you may know, based at Oxford. But we're grappling with many of these issues. We use a Bayesian adaptive platform design. But one of the biggest issues we have is the non-concurrent controls, where in one of our domains, the no intervention group dropped out quite early. And then we continued with our other designs. And obviously this was during a pandemic where, for example, where standard care was changing. So our dropped group is effectively has different concurrent treatments to our ongoing groups, and just trying to work through how we account for that, other than just accounting for time in the analysis, is something that, you know, we've really been grappling. And I mean, you know, no one's done it, so we're open to any suggestions anyone might have.
Yeah, I think it's difficult, isn't it, when you're kind of trying to tackle it as the first to do it, especially when it's in a live clinical trial. I guess a lot of my work has been kind of retrospective and thinking about, oh, how could it have worked, and I guess this is where there needs to be maybe more consideration of like how the theory can be applied in practice. And yeah, it's difficult to know exactly what's right, but I think especially around adaptive designs, a lot of the advice that funders and kind of give, or I guess when I've been to presentations and talks around innovative trial designs, there's always this this kind of encouragement for people to speak to regulators and speak to I guess the HTA bodies to really discuss what the options are and what they'd like to see. And that's one of the bits of advice I've really taken away from various talks I've been to, is like engage with all these people, because like I don't have the answer to your question in terms of like, oh, do this particular statistical method or this approach, but yeah, it's possible that nobody has ever thought of it. And so that, I guess, engaging with stakeholders was kind of something I really tried to do with the development of the research. And again, I think that's generally quite encouraged when you're in these situations, because we don't necessarily know the best answer, do we? So yeah, trying to get the views of everyone. Yeah, so yeah, sorry, it's not really a great answer in terms of solving problems, but just a bit of advice that I guess I've had from various people when developing these methods.
Thanks, Laura. Are there any of the statisticians who are on the line like to comment on the use of VOI for stopping rules, or any experience you've had or discussions with health economists about that? I don't see a huge number of hands coming up to say that they would like to broach that topic. Richard.
Yes, I'm absolutely not a statistician, so I'm going to change subject if that's okay. If no one wants to comment on that specific point, I think that I think that economics alongside adaptive trials is absolutely a coming area. I'm surprised we don't see it more often already. And from my understanding, which isn't comprehensive at all, I haven't seen much of it come through PBAC or medical services equivalent either in Australia. So a couple of questions. In a NICE context, have you seen any practical applications in the pipeline for this? And the second related question is, do you think that the committees are ready for it? Do you think that there is enough understanding and enough support to help policymakers interpret the results that come out of these kinds of analyses, or do you think that there's still an upskilling that needs to be done?
So obviously, I've only been at NICE for a few weeks, so I'm not commenting in my role as someone who works at NICE. But from when I was conducting the research, my sense was that it's not really seen in practice that much. And I think you're absolutely right that there is maybe this kind of need to train, not just kind of the health technology assessment agencies, but also like the funding panel. So people like that sit in the UK, the NIHR funding committees, if they see an application that has these different innovative approaches, they're not necessarily going to be trained in health economics, value of information analysis, or adaptive designs. They could be coming to the panel with a clinical background, and so for them, seeing I guess this is maybe more complex than they're used to design, we need to make sure that they're able to evaluate them appropriately, and that they understand the approach and why it's been taken. And I think it's quite difficult to do, because at the moment the way applications work in the UK is that you get kind of it's unfunded work essentially to design the trial, and then you hope that you can kind of win back that time because the application is funded. But these types of designs maybe require quite a bit more work in terms of pulling a team together. You probably want to pull a team of statisticians, health economists, clinicians to work quite closely and quite intensely to design this study, and to get it right in terms of like the level of detail, and being able to sort of explain it in the best possible way takes time. And you might have a paragraph on a funding application to do that. So it's not even just about like having the money to be able to do it properly, it's also the space to kind of explain things appropriately. And yes, that's difficult, and I think that's something that perhaps needs to change if we want to try and use these more innovative trial designs in practice. So it's not just, so I think, yeah, I totally agree. I think there's more we could do to kind of upskill the people reviewing these applications, and perhaps the same is true in the kind of equivalents of NICE and so on when it comes to kind of further down the line. But also maybe we need to adjust our approach to how we fund the design of trials, and the space we allow to explain some of these more innovative designs when it comes to funding applications as well. They're two things that really came out of the qualitative study, that kind of people were like, yeah, we'd be willing to think about it, but like we don't necessarily have the skills to review these really complicated designs, and how can we as the kind of methodologists produce materials or maybe provide training to facilitate that in practice.
Great, thank you.
I'll just ask one more. Laura, is it a myth that adaptive designs are cheaper and more efficient than fixed designs, given that there are a lot of upfront costs, and time involved, particularly by the statistical team, and the ongoing sort of Bayesian re-randomization? Has anybody looked at that in any systematic way in terms of comparing perhaps the costs and benefits of getting to a treatment response through an adaptive design versus a fixed design?
It's a really good point. I think we often push, people in favour of adaptive designs often push that, they might be cheaper, they might be more efficient, but it's not true for every single adaptive design. And so I recently worked with statisticians in the UK looking at the costs of adaptive trials, and so we tried to think about what differences are there in terms of the practical resources required to design and implement an adaptive trial, and kind of make comparisons between, we had a couple of case studies where we had an adaptive version of the study and a non-adaptive version, and kind of asked the study team, so the people who would generally think about how much a trial costs, maybe study managers and like clinical trials unit kind of administration teams, to think about what the differences might be, the extra statistician time, the extra data management time required for these trials. And so there are a couple of papers published on that kind of try and draw comparisons and say, well, if you're thinking about adaptive designs, here are things that you might want to think about. So I'd be happy to, I could find the papers and maybe someone
Yeah,
could
if
share
you
a
could
link
send
to
through
the
a
group.
couple of links,
Yeah.
possibly through to Michael, that would be
Yeah.
terrific. Thank you. And possibly you've mentioned 3 or 4 papers that you've published that might be useful as well, if you'd like to give us your sort of PubMed output of your citations on this topic.
Yeah.
I think people would be very interested. Okay, Richard, are there any more last questions for Laura?
No, there was one just point in the chat from Julie Marsh who flagged that, yeah, there's a huge amount of additional information that you provided, which is really valuable. I think the statisticians tend to hand wave and claim the expected bias of adaptive designs is relatively small, but I think you've shown that can be true, but isn't necessarily so. So thank you for that. Rachel, did you want to close out the session?
Sure. Yeah. Look, thanks very much, Laura. I think that's been it's been terrific to hear from you, particularly about your PhD research. And apologies if we grilled you a little bit on your role at NICE and inside information. But no, it's been incredibly valuable to us as a group of methodologists. So on behalf of the ACTA HEAT Special Interest Group, I'd like to thank you very much today for your presentation and engagement with our questions and groups. Apologies again, it's very early in the day for you, but wish you a very good rest of your day. And now we can close this meeting. We will have follow-up